Hey, what's happening? Happy Monday, family, transplant warriors, guests, donors, recipients. I love you guys. Hello, hello. I am so happy to be back here with you guys again. Oh my gosh. So, we've got so much to cover today. And for those that don't know, this is National Diabetes Month. So I really wanted us to have a show and focus on that. Hello, Candy Girl. Happy birthday to anyone whose birthday is today. If it is your birthday, chime in. If it isn't, that's okay too. Chime in and let me know you're here. If I could say hello to you real quick before I get started, I will. Also, please don't forget to smash that like button, share, okay? Share this show to your page. I know everybody has someone in their family or their personal circle that has diabetes. I have no doubt about it, okay? And we really want to get this word out, especially this month. We want to encourage you and educate you on this illness. You know, diabetes and high blood pressure are the two leading causes of what? Kidney disease. Yes. So also be mindful to put your questions in the chat box and your comments. Also, we are live on YouTube. I know not everybody has an FB page. So for those who don't, maybe in your family that you'd like to share this with, it's always recorded and you can go over, they can go over to YouTube and check that out. Don't forget, sharing is caring. So share this page, everyone. Now, I want to start out with telling you a little bit about my situation. I was diagnosed with type 2 diabetes about 2 years ago. Yes, I was. Now, the interesting thing is that I am maintaining, I shouldn't say it's interesting, it's really a blessing. I'm doing very well at trying to maintain this on my own. But it is a lot of work, guys, doing this. Really, it's not for it's not for the faint of heart. I shared the other day about how much water I chug every day, definitely no less than 64 ounces, which is actually what they say should be our day norm, the equivalent of 8 glasses. Yes, that is a lot of water, but it can be done. It was my choice not to be put on a medication right away. I wanted to give myself a chance to see if I could get my A1C down on my own. And I've been doing pretty well with it. Now, I would not always advise that for everyone. I think it's best that you listen to your doctors, your diabetes educators. They are the ones who know your situation. So just be mindful of that. If you need to be on those medications, you get on them and you stay on them until the doctor says differently because some folks' diabetes is out of control. Hello, welcome, come on in. It's so good to see you guys chiming in. So I want to give you just a few stats about diabetes. Know that, which is short for new onset diabetes, happens a lot after transplantation. I'm pretty sure that was my issue. For those that aren't aware, praise the Lord. Next year, 2022, in March, I will be 17 years post-transplant. Okay. Hey, Jim Myers. How are you, Uncle Jim? Now, that occurs in 4 to 25% of renal patients, 2 to 25% of liver patients, and 4 to 40% of heart recipients. And so why do we as kidney recipients get diabetes? It's our anti-rejection meds oftentimes. That's what leads us into it. Our immunosuppressant medications have become so much better, though, in the prevention of rejection. Yet, we also know that there's always a trade-off, right? So, our meds sometimes can fix one thing to break down something else. And many of our transplant warriors deal with this, and they know someone else who's dealing with it. So let's put those questions and comments in the chat box. Almost, last stat, 35 million Americans in the United States alone, okay, are dealing with 34 million Americans are dealing with diabetes, and at least 1 in 3 of them, it's type 2. Okay, so this is really, really, really important, really important. So I really want you guys to really come on in with this, come in with your questions. If you are a diabetic, share that in the chat box too. All right, let me tell you a little bit about my guest for the show. She is an amazing, wonderful, and caring woman. Her name is Laura Gill, and she is a registered nurse at Tampa General Hospital. She has a bachelor's degree and a master's in nursing, as well as being a certified diabetes care educator. She is a specialist in this. I know, I've seen her before. She's awesome. She's been working at TGH for almost 24 years, teaching patients, family, staff members about the importance of diabetes education and management. She also facilitates a diabetes support group, which groups are the best. I love the support groups because everybody can get together that's dealing with this issue and be supportive of one another. But for my audience who are also maybe Spanish speakers, she's bilingual and she teaches it in the Spanish community as well, which is really great. So please, 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 let's give a warm welcome to my guest speaker, Jared, and shout out to my producer, Jared. Let's go. Hi, Laura.
Hi, how are you? Hi, everybody.
Oh, thank you so much for joining again, Laura. It really means a lot to me because I know you guys in the medical field are working really hard. I know a lot of you are working longer hours, and I know it's a lot going on because I'm in, of course, a lot of the TGH meetings too. Being on the board there. So I just really appreciate you taking some of your personal time to come and educate my audience. So thanks again so much for that.
It's great to be here. Thank you for having me.
Absolutely, absolutely. So I'm going to come right on out with our my first question for you, which is a very basic one. And I'm sure many of the audience probably are aware, but there's also probably many that are not. So could you please explain what is exactly diabetes and what is the difference between type 1 and type 2?
Sorry, I didn't get the last part. My
Sure.
connection is coming in and out.
That's okay. I was asking for you to please explain what is diabetes and the difference between type 1 and type 2.
Oh, okay. So diabetes is a metabolic disorder that happens in person with well, type 1, let me explain that type 1 and type 2. So type 1 usually occurs in children, and it is a group of metabolic disorders. Type 1 happens in children, and it is an autoimmune disorder where the pancreas isn't making insulin anymore. And it could occur in older adults as well. And those persons, they always need to use insulin. They can't use pills for diabetes. And it is controlled with diet, exercise, and exclusively insulin. In type 2, it occurs in usually older adults and in persons who are overweight and usually have diabetes in the family. And when it occurs, it sometimes can be controlled with diet and exercise, and it can be controlled with pills or insulin, pills and or insulin. If when it's discovered though it's uncontrolled, then that person needs to go ahead and go directly to insulin, especially if the hemoglobin A1C is greater than 10%. Then the American Diabetes Association would, go ahead and recommend that the person needs to go ahead and start on insulin. Sorry, I can't hear.
Okay. Let me know if you can hear me, because I'll keep
Okay,
talking.
I can hear you now.
Can you hear me? Okay.
Yes.
Okay. So you stated that oftentimes type 1 is seen in children. Now, would that be considered the same as like gestational diabetes?
No,
Did you hear?
gestational diabetes occurs during pregnancy, and it usually occurs in the third trimester, but it can be in the second trimester. And the person during pregnancy, and once the baby's born, the diabetes away. The mother has a chance of developing. If you have a history of gestational diabetes, then you can get a type 2 diabetes in the future. You have a higher risk of developing type 2 diabetes in the future if you have had a history of gestational diabetes. And there's also steroid-induced diabetes, which is common with transplants, or people who have asthma, history of asthma, or if you've had a steroid injection because of inflammation in your knee, or you have arthritis, you could get steroid-induced diabetes, which is usually a temporary situation, but it can go ahead and develop into type 2 diabetes, especially if you have pre-existing risk factors like family members with diabetes, or you're overweight, or things like that.
Okay. Can you hear me okay before I move on?
Yes, I can.
Okay. So, being someone that deals with type 2 myself, I was just wondering, is it ever considered type 1 being worse than the other? I know I've had a lot of mixed comments about this from people who deal with diabetes. They feel type 1 and I guess that's because they feel because you have to be on insulin injections, every day, that that's probably worse than type 2, which only pretty much requires medication. What would you have to share about that?
I get this question a lot, especially with newly diagnosed. They want to know which is worse, is type 1 or type 2. And my answer is always the same. Either one can be, because you're going to get the same type of complications if the diabetes is uncontrolled. So if you have type 1 diabetes, you could live a long, healthy life with an A1C of 6, of 5, as long as controlled. If you have type 2 diabetes and it's uncontrolled, and you're on insulin, you could still have insulin shots every day and an A1C of 14 and have all these complications, either or, type 1 or type 2. You could have complications. You could be on insulin shots, all the time, 4 or 5 shots a day, or an insulin pump. Either. So I would say either one could be worse if it's uncontrolled. The solid answer.
Okay. Okay. So my next question is, I know many people are confused about, because I know I was super confused. First of all, when you're hit with that, I mean, when I was told that I was a pre-diabetic, I wasn't unfamiliar with it because there were diabetics in my family in close, range. And I remember in the beginning of my introduction, for the show today, I stated that gave some stats about how it's so prevalent with transplant recipients. However, which is, I said, probably definitely what started the onset of mine, the immunosuppressants, but slash that, it's in the family as well. So unfortunately, it's like the double whammy.
You had risk factors.
Exactly. There were already risks. And I will say this too, I've noticed, I know a lot of people, it is oftentimes associated with weight as well, but I know many that are really small and in shape that are diabetics, which I always find that so interesting,
Yes, ma'am.
And I'm sure you see that as well in
I do.
in what you dealing with people too who have diabetes. But what was such a struggle for me, even more so than being diagnosed with kidney disease, I knew exactly where to hone in to learn about that. There are so many facets to diabetes, to figure out what this is. Well, what does this mean? Well, you got to be careful, because if you don't, this is going to send you into this. And I'm going to go into that a little in a minute, more so what I'm speaking of when I stated that. But I was very confused about A1Cs, and that being over a 2 or 3 month period. So I would like for you to kind of explain about the A1C test. I think it used to be called the hemoglobin A1C even, but what is that? And what do their what does that result mean every time those are checked, the A1C?
So the hemoglobin A1C is still called an A1C, but hemoglobin A1C, but they've shortened it to A to make it easier for people to remember. And these tests are recommended. That hemoglobin A1C is recommended by the ADA to be done every 6 months. So
can you hear me, Laura? You froze up.
I'm sorry. Can you hear me now? So this is the hemoglobin A1C. Can you hear me now?
Yes, it's freezing a little bit. Go ahead.
So it's recommended to be done once every 6 months in people that are controlled, and uncontrolled, it's recommended to be done once every 3 months. And what this test is it's a blood test that looks at the red blood cell, and it looks at how much sugar is stuck on the red blood cell, and it measures the amount of sugar on that red blood cell, and it gives you a percentage of that sugar. And then, so like an estimated average. Can you see that? An estimated average sugar over the past 3 months. And so this represents the amount of sugar or the percentage of sugar on the red blood cell.
Okay.
And then it gives you an estimated average glucose over the past 3 months. 3 months, because the blood cell lives for a period of 3 months.
Okay,
So
okay.
Does that make
Yes, you just told me something I didn't know.
Yes. So that's why when you're a 7, your estimated average glucose is about 154, because it's measuring that amount of sugar on the red blood cell. Because your red blood cell lives for a period of about 2 to 3 months. And that's why, yeah. And so that is one of those preventative care tests. And it's recommended, as I said, once every 6 months for those who are controlled, and once every 3 months for uncontrolled blood glucose.
Okay. Thank you. Yeah. So me personally, guys, I have, my doctors have mine checked. My endocrinologist, which is the type of specialist you see with regard to diabetes, checks mine every 3 months. In fact, all my labs are done every 3, my transplant labs as well. So they combine all of them together. I average about my A1C every 3 months is running about 6.5. Sometimes it gets a little close to, sometimes it gets a little close to 7. So it kind of will fluctuate a bit. And I just want to share, I remember one of the main things that I literally hated during the beginning and trying to learn everything about it was the finger pricking. And it wasn't because it hurts. Some people like freak out about needles. I'm not one of those. If you go through dialysis, most people aren't afraid of needles. But I got so tired of that. And then that's when it's time consuming and you got to lay everything out. And so one of the greatest discoveries for me was when my endo presented the Freestyle Libre to me, which is, if you guys can see that, that's on my arm. Okay, guys.
Awesome.
This allows me to not have to prick myself. This gets changed every 14 days. I have to take this one off and put a new one on. Now there is a very tiny needle in it, because obviously how could it, know my my glucose readings if it wasn't something that pricked, but it doesn't hurt. It's really quick when you snap it in your arm. And then I monitor everything through my cell phone. Okay, this gives all that information every time I zap my arm. And in fact, I'm gonna do it right now as a little demonstration, because this is how it's done. Okay, see, it beeps and it gives me a little reading. Now, I've had my dinner recently. My glucose right now is 115. Now, that's not bad. Thanks. Yay, Laura, that makes Laura happy. That's not bad. So this thing is amazing. I would suggest it to anyone who is a diabetic. Get the Freestyle Libre. Your insurances will usually cover it. So that's just, something to put out there to you guys. So Laura, my next question is, this is where those highs and lows come in, the difficult stuff about diabetes. Some things are very cut and dry. And then there's the thing where it's sometimes hard to get that balance that you need. And if your glucose drops too low, you can develop something called hypoglycemia. Could you explain what that is to everyone, please?
So hypoglycemia is when the blood glucose drops too low. And when that happens, hypoglycemia definition is below 70. And you'll have symptoms. The causes are either not enough food, too much insulin or diabetes medication, or an unusual amount of activity. And it's those are the causes. And it usually comes on suddenly. And I have a little sheet here. It usually comes on suddenly, and it could lead to a medical emergency. You could pass out. And the symptoms are being cold, clammy, sweaty, heart beating fast, hands shaking. You won't feel good. And the treatment is easy. Just juice, milk, regular soda. 4 ounces is all you need. Just drink that down. Glucose tablets will work too. I always tell people, keep a small juice box with you at your bedside table. I always another thing, whenever you're taking insulin in the evening, you may want to have like a small snack before bedtime. If you're prone to having those like in the middle of the night, low blood sugar or hypoglycemia, like have a carbohydrate with a protein. So it could be like a half a turkey sandwich, or a half a two fish sandwich, or a half a grilled cheese, something like that. A carbohydrates up with your proteins. Yeah, but those are just some snacks that you could have before bed. Avoid hypoglycemia. And another thing, whenever you're going for a long car drive, you'll want to check your blood sugar. Whenever you're going to go for a bike ride, or go for some long exercise, to avoid hypoglycemia, you want to check your blood sugar prior to going. You have a wonderful device on your arm that alarms for you,
Yes.
and let you know when your blood sugar is dropping, so you can go ahead and treat it. But yeah, hypoglycemia is whenever your blood sugar is dropping really low, below 70.
Yes,
Yeah.
yes. I've had that happen once or twice. And I'll tell you guys too, it happened after I worked out, especially if my workout is kind of aggressive. You know, the blood sugar will drop. And these are the little parts where I said it's like, you know, like a teeter-totter, you know, it's like, okay, you're good. Oh, dropping too low. And so I agree, Laura, it's very important to have on hand either the glucose tablets. I have that. I have this whole like kit, this whole like emergency like thing I carry that stays in my car. I have, you know, like things like that will bring it up really quick. Like what you stated, I keep like these peanut butter type crackers in there, things that are non-perishable, of course, that are really helpful with getting that glucose, you know, back up, as opposed to just eating some chocolate or whatever. Orange juice, a few sips of that is great as well. I do want to address one statement, Jared. I think it was Lisa Smallwood that had it on there. Can you put that up? Because I think she was mentioning something about her sensor, and I just want, okay, so yeah, that's what I have. You've got problems. You have problems with your sensor. Now, I don't know if you mean that's all the time, Lisa, or just there have been times when you have had problems with it. But what I can tell you is that I've had that happen with one of my sensors. I went through the whole process of putting a new one on, and it would not work. You know, it just was, something was going on. These sensors are expensive. And so I called the company, and they were very apologetic. They know how critical these are to diabetes patients. So they right away overnighted me a new sensor, and even threw in an extra one, you know, for the inconvenience. So I would suggest, if that happens to you, call the company number on the box, and they will take care of you. They will send you another sensor. And then we have someone who said that they're very lucky that they didn't develop diabetes even after, oh, okay, they had a kidney removed. Yeah, yeah, that's really good. And yeah, I hope the exercise definitely plays a large role. So next question, Laura, is what, you kind of touched on this a little bit. Actually, you actually did touch on this because that was going to be my question, and it kind of led us into it with regard to what would affect a person's blood sugar and how can you get that up. So thank you. We got that out the way. But what I want to talk about now is tell us what a basic diabetes education, what you do at Tampa General Hospital, what does that consist of? And especially for a first visiting patient.
So if a person like is when they're newly diagnosed, we'll go see them, and it depends. If let's say they're newly diagnosed and they're starting on insulin, we'll go and see them, and we give them this booklet. And so this is what they'll get first. And we talk about the 4 things that they need to do on a daily basis, eating healthy, exercise, checking their blood sugar, and taking their medications faithfully. So these 4 things are like cornerstone. They'll do these things every day. We talk to them about what types of diabetes or what type of diabetes they have, whether it be type 1 or type 2. And we'll give them a blood sugar meter, and we'll teach them how to use.
Okay, you've frozen on me, Laura.
Sorry.
That's okay. I heard you say you'll give
me?
them a blood sugar meter, and then that's when it cut off. Mm-hmm.
Oh, okay. We'll give them a blood sugar meter and teach them how to use it, depending, of course, on whatever insurance, because the strips are expensive. So we'll match it to their insurance, and we'll teach them their insulin. If they're on insulin, we'll teach them their insulin and go over their insulin plan with them, and we'll go over meal planning. We'll talk about carbohydrate counting. And we'll teach them the difference between carbohydrates, proteins, and fats. And we'll go over label reading and about the plate method. So we'll go over the portion plate and there, and we'll kind of show them how we cut it in half and fill 1/4 of the plate with non-starchy vegetables, 1/4 of the plate with protein, and 1/4 with starch, and then have the milk and fruit on the side. And if it's a woman, we'll teach them 45 grams of carbs per meal. And if it's a man, it'll be 60 grams of carbs per meal. And we'll give them a meal planning guide for either 1,800 calories or 1,500 calories. If it's a taller person, we'll give them 2,000 calories. And we'll talk about the benefits of exercise, recommend 150 minutes per week, depending on the person. Obviously, if the person elderly or they have limited mobility, we're not going to be forcing too much exercise, but we individualize the teaching to each person.
Okay.
And same with testing the blood sugar. It'll be, if a person is going home on pills, we'll recommend, twice daily testing. Or if they're going home on intensive insulin regimens like basal bolus, like, twice daily or 4 times daily insulin injections, then it'll be, 3 to 4 times a day testing their blood sugar. Also give out the freestyle or the freestyle Libre, and we teach them how to use that. And we do give the Dexcom as well. That's for newly diagnosed, and we go through care, recommend eye exam once a year, kidney function tests once a year, and foot exams. the A1C test, healthy, weight, keep a healthy weight, cholesterol, high blood pressure, keep the blood pressure in check, all of those things, and follow up. And we also recommend the follow-up diabetes classes. So, we do like 1.5 to 2 hour sessions with the patients in the hospital. And then, of course, we will see them outpatient. And our outpatient classes are 10-hour content, the diabetes self-management education classes. They're 5 hours for 2 days. They provide lunch both days. And it's a comprehensive class with different multiple interdisciplinary class with multiple teachers. And there's like a PowerPoint presentation, and they go over different topics. They have like a podiatrist and a dietitian and certified diabetes educators in the class, exercise specialists. So it's a really good way to get on the right foot with newly diagnosed, learning about diabetes and how to take care of it. And that's really what you need, because there's so many things that you need, to take care of with diabetes. It's a lot. I mean, eye care, dental, kidneys, heart. There's a lot of things that are involved with diabetes. It's not just one thing. There's lots of body systems that go along with diabetes. So
Yeah.
it is people with diabetes understand everything that goes along with it, and that they get the care that they need from all of the different specialties.
Mm-hmm. Mm-hmm. And thank you for sharing that, because just even in that is a lot of information. You know what I mean?
Yes,
And
it is.
yeah, it's a lot. It's like I tell people, I did a video earlier today. I was making my lunch, and I was just sharing one of my favorite salads that I make, and just how much water I drink, and I tell people, trust me, I am by no means, don't think that this just comes so easy for me, because this is what I do. That takes a lot of discipline, and it's over time, because you're gonna fall short.
Yes.
But you got to get back on the horse when you fall off of it, because if you don't, there's that fear factor, So it's a lifestyle, and that is what diabetes is to me. Now I have, I feel, to the best of my ability, conquered, for the most part, kidney disease. Now here comes Mr. Diabetes, and so now this is another entire that I had to adjust to, and make so many adjustments, especially to keep it from escalating, which is the best way, and I'm sure you probably agree, to do it. Grab hold of it in the beginning before it spirals, out of control. And so what would you say, and then after this, I have a question, i.e. comment about weight. What would you say, where do you feel, Laura, that aside from it being genetic, aside from, the fact that, again, our medications cause this, where do you think people are going wrong? In what capacities in their, in their day-to-day lifestyles, that so many, I mean, millions and millions of people are just coming down with diabetes?
Now say that again.
Yeah. So, I mean, I know that oftentimes, for the most part, the diabetes is predicated on genetics. And for us as transplant recipients, a lot of ours comes from our medications. What are some of the other things that you're seeing in, being skilled in diabetes and an educator? that are the causes of diabetes? Is there anything else outside of, like I said, I know athletes, their bodies, and they're great physiques, they're healthy eaters, vegetarians, vegans. They don't smoke, don't drink. And I've asked some of them, is it in your family? They're like, nope, nobody has diabetes in my family. So it really puzzles me as to, what else could be out there, potentially that's causing this. And I was just wondering if you had any thoughts on that.
Now, I was just looking at something here that I pulled up from the CDC, and it says here that in the last 20 years, the adults diagnosed with diabetes has more than doubled in the American population, or more than doubled as the American population has aged and become more overweight or obese. I do believe that the foods that we eat have a lot.
You froze up, Laura. I heard you up until the foods that we eat.
I do believe that the foods that we eat play a huge role in a lot of the things, the cancers and diabetes and the sicknesses, the ailments that we are seeing today. I of course they would have to do testing, but I do believe that the foods that we eat, the processed foods and the pesticides and things that they're putting on foods, that they inject animals with, things bigger and just I do think that the foods that we eat are not the healthiest, and it's hard to get away from it. It's in all food. So and our obese population is just it's an epidemic in and of itself, and I think that's what is causing a lot of the.
You frozen. You said it's causing a lot. Are you there? Can you hear me?
Of diabetes, diabetes and cancers and these, all of these sicknesses. This is a theory. I can't sure, but it can't be good for us. The things that they're injecting animals, that they're feeding animals, these GMOs and all these things, right?
Yes. It's mighty funny though. This theory that we have, a lot of us have it, because I have actually said the same thing, Laura. That's why I wanted your opinion. It's in a lot of these processed foods. One thing we need to really stay away from is processed food. Everything today is about quick, fast. Let's get it done. Let's pop a meal in the microwave. And, we have gotten so away from the tradition of how we were raised. The meals, we got the same animals, but they're not being raised, in the same way, with the same love and care in the way they were fed. And, and I know I shared earlier in my video, my grandmother, most of our food was fried, unless it was a holiday. Thanksgiving, the holidays, Easter, Christmas, when you do the turkey thing. Oh my God, we weren't obese children. That's what really scares me now today, especially when I see young children with diabetes or that are obese. And I'm looking like, oh my God, no, they're not active enough anymore. We got outside, we played every day after school when we did our homework. These kids are the computer age kids. They're in front of the televisions, the games. It is just such an unhealthy unhealthy time.
Video game.
It's all too much. And again, they're the future. So it is just really sad what we're seeing. I want to throw this out there. Jared, Jared said, would you say that a low carb diet is a good idea for more people?
I think that we should have some carbohydrates. I don't think that to eliminate carbohydrates from our diet is a good idea, but I do think that low carb, like carbohydrates in moderation, is good. You know, like you do need some carbs. Fruits are healthy. Fruit is good for you. Milk is good for you. I don't think that you should just eliminate those types of things from your diet. I think you should still have those.
And speaking of fruit, I learned too that to me, all fruit was just great and healthy, you know, and I didn't look at it as sugar, you know what I mean? But I did come to learn that some fruits obviously are higher in that content. So I had to really master which ones those are and which would be, you know, more, you know, conducive to me ingesting that wouldn't elevate my glucose. Is that correct as well? Certain, you know, fruits?
Yes, yes. I mean, I have a friend that does like a no carb type of diet, but she'll eat like those jalapeno poppers.
Yeah.
You know, and that's not healthy. I don't think that fried thing, like a fried vegetable that is with cheese in it, and it's I don't think that would be as healthy as like a banana, for example, you know. So
Right.
I think fruit would be healthier than that fried thing, you know.
Yeah. And of course, veggies is always a freebie. You know, eat as
Yes.
much as, I mean, that's what I was like, eat as much as you can hold.
Yes.
Everybody, I think, like some type of vegetable that you love, that you are fine with eating in a little more abundance or every day. I know I have my favorites. And
Yes.
again, it's that repetitive behavior that leads us into healthier eating. And you'll find that your body doesn't want that stuff. I mean, there's been a few times, yes, lots of vegetables, Jared, that I went to treat myself to something thinking I've been a good girl this week. I'm about to have me a few bites of some carrot cake. I love carrot cake. Okay. And or a certain food that I don't eat. Like I haven't eaten beef and pork in like 19 years since I got diagnosed with kidney disease. That was what started my change of eating and developing that type of control and discipline. And they were like, no, you don't have to cut it out. We just want you to be more in moderation about it because, you know, you spill a lot of protein when you're a recipient. I said, nope, cutting it out, don't need it anymore. And when I got transplanted, oh, you can go back to everything you was eating. Well, by that time, almost 12 years later, I didn't even want the stuff anymore.
We're used to it, yeah.
I was used to not having it. And if I had it, it sent me into a mini bathroom trips or stomach ache, which I never did that. I'm saying just, you know, certain things you cut out your diet when you're used to it. And so one thing I wanted to ask you about is what's really big in the industry is weight, lose weight. Oh, you just need to lose some weight. Okay. So, and I know this is a really important thing in relation to diabetes. I get it. However, I will say this, as recipients, I think we have all gained weight during our journey. Most of us. And the ones that haven't, they were probably just genetically small or, you know, theirs had a different type of adverse effect on them, their immunosuppressants, which caused them to lose weight. But it's so easy to tell people to lose weight. And we all know it is not easy to lose weight. Oftentimes,
it is not.
Especially older, don't work like that. I know mine doesn't anymore. It's like
No.
a few pounds here and there, which is great. So you just try to maintain that. So what do you say to a patient who literally is either unfortunately considered medically morbidly obese, or can you hear me okay?
I can.
Okay, I'm sorry. Or who just says, Laura, I just can't. I'm trying. I can't lose any. So then how do you respond to that, to that patient?
Well, there are different ways that work for different people, and different meal plans work for different people, and portion control for the most works for people.
Mm-hmm.
So, and so what I do is I give them a meal plan that has like 14 days of healthy menus, and I I give this to stick to the plan. Now, it isn't easy it isn't easy, and if somebody is morbid obese, a lot of times they may need to get counseling, and a lot of times, they may need a consultation with our bariatric, service. So
Mm-hmm.
for most people, I hesitate to say that because I don't like the idea of turning straight to surgery. But when you think about when I think about someone who's morbidly obese and they've tried everything, and they just don't have any other way out, that might be the answer for them. That might be the only answer for them. And if it's between, the surgery and then, it just depends. If they're a candidate for it and they go through the psychotherapy and everything, and the doctors decide that this person is a good candidate for bariatric surgery, then they will go ahead and give them or recommend them for that surgery. Again, I don't like it, and wouldn't be my first choice. And it's not for everybody, but a lot of times they'll try psychotherapy first. They'll try to talk to the person and see if they could try other methods and different meal plans first. If a person, when we're talking about morbidly obese, maybe a person weighs 400 pounds and it's their health is at risk, then this person absolutely needs to have
You froze up a little bit, Laura. Laura, can you hear me? Laura?
Can you hear me?
Yeah, you were totally frozen for a second there.
Oh, no.
Sorry about that. So you, gosh, where'd you leave off? So if this, you were talking about if the person needed, that's where you kind of froze up. Whatever.
Okay.
Yeah.
So if the person absolutely needed, and you could say I struggle with this. I struggle with this because I don't like it. I don't like this. If the person absolutely needed this surgery, and because and my example, they were 400 pounds and they needed this for reasons, then yes, to bariatric. But if we could do it any other way, and we could do it with diet and exercise and a trainer and a really good diet, then I would try that method first. And the only reason I say that, and I'll tell you why I say that, because I had a personal experience, and I'll share this with you. I had a patient when I first started this job, and I went in to see him, and he was so excited. He was like a 40 something, and he was like 350, probably weighed 350. He was young, he had a family, and he was going to surgery, and I said, oh, I'm here for diabetes education. He said, can you come back tomorrow, because I'm going to surgery, and this diabetes is going to go away as soon as I have this surgery, but I'll be happy to talk to you tomorrow. I came back the next day, they had the door closed, and he had passed away because, and not to scare anybody off, but he had passed away because he had a blood clot, and yeah. And so I really don't like this surgery, and I know it's successful for some people. I know people that have had it and it's successful for them, but I really don't like this, and so, and that's why I get uncomfortable when I even talk about it. I don't like recommending it. I'd rather do a diet. I'd rather try it first. So I've struggled with weight myself. I've lost 60 pounds. Not 60. I've lost 40 pounds, and I put it back on, and I've lost it again. And portion control. That's where it's at. And whenever I have lost weight, I've done Atkins. I've done, and I've gained it back. The best thing that that has worked for me personally, portion control. Not everybody, not every plan works for everybody.
Correct.
Day would do what works best for you, because everybody's different. What works best for me, it may not work for you, but don't stop trying. Don't stop trying.
Exactly. I agree 100%, Laura, with what you said. Everything that works, what works for one person may not work for the next, and that's okay. That's where you don't get frustrated, But what people are, many people who have been successful at extreme weight loss, especially, I know Jonathan, he had a post up a little bit ago where he was talking about how he really overindulges in his salads and things like that. Jonathan is a recipient. I saw the photos where, he had tremendous weight loss and looks great. I've seen many people do it on their own. You just have to want to do it.
That's
keto
right.
diet isn't going to work for everybody. Why isn't it going to work for me? Because first of all, I don't eat a lot of meat. I don't eat, beef and pork and things like that. So a couple of people say, hey, you ever tried, just in conversation, keto diet? Nope, I don't eat big. Oh, okay. So just like every supplement, vitamin, everybody can't take that. You have to know what works for you. And that's the most important part. And that was a very sad story that you shared. And I'm not saying that everybody that wants to get that type of surgery, I remember when it was called bypass when it first came out or something like that, that you're right. I've known some people that had it and it has worked for them. However, I have noticed such significant weight loss in many of them where they don't look healthy. They just don't look healthy. Their bodies get really, really tiny, and then it's weird. Their head looks really big, and that's not how you want to look. Just because you lose a lot of weight don't mean you're healthy either. Doesn't mean everybody small is healthy. So there's just a lot of dynamics with that. But before I let you go, Laura, I just have one more question for you, because I think this is really important. And something I was just wondering about is because COVID plays such a big role in our lives today, unfortunately, that oftentimes it seems like, I'm not going to say forgetting, but just, I didn't see much advertising going on for National Diabetes Month. There are illnesses that get much more widely advertised, such as breast cancer. We're women. We have love for all of our women that get that. However, there are other things out here that need special attention in the media as well. And I didn't see much for that regarding this month being Diabetes Month. But what I wanted to ask you is, how is COVID affecting the participation, the education, and preventative care in relation to diabetes?
So, yeah, and we talked a little bit about this before the show. I I haven't seen much either. On beings, this is National or World Diabetes Month. November is World Diabetes Month, and in the past we saw um, uh, uh, in Paris, the Eiffel Tower is lit up in blue, and in downtown here, downtown Tampa, everything's lit up blue, and haven't seen that in all month. And even now, like our list in the hospital is down really low. It's half what it usually is. And our patients, we usually have a large number of patients in our classes, and now that everything's virtual, we're going back to live in 2022 in January. But we have lower attendance and everything, and I do believe that it is due to COVID that we're seeing less people doing preventative care, eye exam, foot exam, they're twice yearly A1C tests, and all due to COVID. So I think it is affecting people, that diabetes and their follow-up care, their DSME classes and things. And I hope that in the coming year that will change, and we'll see a more attendance and a better outcome next year for people with diabetes, and better participation from the community as a whole for people with diabetes.
Yeah, yeah. I pray that will be the case too, Laura, because I just think that, with everyone being so consumed and preoccupied with COVID, it's just taken away, from so many things that are as equally important out here that need a lot of focus. And this is definitely, diabetes is definitely one of them. I think many people will also, possibly something that could be prohibiting that a bit, become so complacent with just, okay, I'm on my insulin, I don't have to worry about this anymore. I can, eat what I don't need any more education. I know, and that is so not the case. And
That's
so, in fact, what we're seeing in the hospitals, and the doctors in the meetings keep implementing this. Unfortunately, those that come down with COVID that have these issues, it's so much more brutal on you, which is even more of a reason, right, to really grab hold of it, hone in on it, make sure, like you said, all you can do is what you can do. Of course, if you got it, you got it. But make sure you're doing everything that you can as a preventative measure, your regular doctor's visits, your regular educational things with you, your eye issues, because that diabetes definitely affects the vision. I know I went back, I had my eye exam for the year. I'm faithful with it in January. However, I did not get a dilation because I had some other business to take care of afterwards. And the dilation can really be a little difficult because the sun is a really bad glare. So I went back though, and got that, because that is really critical to have.
Absolutely.
You can see
Yeah.
if there's anything going on with your eyes. I mean, nobody wants to be blind, you know what I mean? So you don't have to tell me twice, you know? And I just want to see more people really do, you know, the right thing by their bodies, even, you know, with this illness. It's just so important. So I'm really happy to hear you guys are about to start up again in January. I know I'm looking forward to get back into my zone at TGH. I miss seeing the transplant patients, and I miss coming to the meetings, you know, myself, which are very helpful to people. You know, we encourage each other and motivate each other, and this is so needed, guys. And so, Jared, before I let Laura go for the night, I know she probably has work tomorrow. Were there any questions that we missed real quick? I know we had some great comments coming through, which was really good. Just saying how much they appreciate you, Laura. Yeah, we definitely do. We need to have a calorie deficit, burn more calories than you ingest. Absolutely, Steve. That is so true. So before I close, Laura, I leave everyone with the scripture that pretty much is I kind of, you know, kind of pray about that, to personalize it toward them. But this is such a great scripture, and it just, you know, I think you would agree that it's so befitting in itself of relating to diabetes, and it comes from the First Corinthians 10:31, and it's very, very clear, which says, "So whether you eat or drink or whatever you do, just do it all for the glory of God." You know, because these bodies are his temple, that our bodies belong to him, and he's not a God of sickness. And so I was like, what this scripture in essence is really telling us is, when we bring God into our health, to eat healthy, it changes everything, guys. It changes everything. And striving to, you know, give honor to him in our food, what we're putting in our bodies and what we're drinking, and those choices that we make will bring us not only a healthy heart change, but it will also change our choices. And that's real. It will. You can do it. I believe in you guys. I love all the little favorite foods too, but I want to live. I am here. I want to see my granddaughters grow up. I want to see my daughter have her first child. I want to be here. And I want you guys to be here for your family. And I want to thank you, Laura, for taking time again out of your evening to come and educate us. I really, really, really appreciate you, dear. And I know by January, I will be seeing you in the hospital. I'll be coming probably to visit you.
Thank you for having me.
Absolutely. Thank you so much. And you have a blessed night.
Thank you. You too. Take care.
Okay. Bye-bye.
Bye-bye.
Wow. Well, guys, I hope that you were blessed by this show. I hope that maybe you learned something, even as a diabetic, that you did not know. I want to say, you know, we got Thanksgiving coming up. Actually, a couple of things I want to say about that. Okay, this is the time where we eat, 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 eat. Yes, let us celebrate the life of Cy Speaks. Oh my God, rest in heaven, Cy. We love you. I am very honored to have been a part of the second half of Sisters Against Kidney Disease. And please be careful with your eating for Thanksgiving. Enjoy the food, but don't make the food, but don't let it make you. How about that? So I will be visiting family. Normally, you guys know my show is every other week, but I actually won't be back until the first Monday of December, because I'll be going out of town. And by the time I come back, I won't have the time to put a show together. But I just want you guys to have a wonderful and safe holiday. Continue to wear those masks, protect yourself. I pray for you guys to have a safe trip. If you're going out of town, please pray for me. And just know that Jesus loves you, and so do I. And there's nothing that you can do about it. Bye. Have a good one.